Good morning, colleagues. It's the appointed time, and we have a quorum. I call to order the meeting of the subcommittee. Let's first invite representatives of the Civil Service Bureau to come inside the conference room. Now, today we are to discuss exploring the provision of medical benefits for civil service eligible persons CSEPs by mode other than the public healthcare service. It is item E of the list of major subjects to be studied by the subcommittee. The administration has issued a paper to talk about the relevant provision of medical benefits. The next meeting of the subcommittee will be held on 27th of February, Tuesday, 10:45 in the morning. We will discuss item F in the list of major subjects to be studied, that is post-retirement medical benefits for CSEPs. Members, do you have any comments in relation to the topic to be discussed? If not, we'll move on to agenda item number 1. Exploring the provision of medical benefits for CSEPs by mode other than the public healthcare service. I'll remind members that in accordance with Rule 83A of the Rules of Procedure, members should disclose the nature of any direct or indirect pecuniary interest relating to the item under discussion before they speak on the item. I would first like to make a declaration of interest myself. I am a retired civil servant, Mr. Dennis Leung. I would like to declare that a family member of mine is a retired civil servant and another one is a current civil servant. All right. There being no other questions, we'll have the secretary brief members on the paper. Thank you, Chair. Today we are to talk about exploring the provision of medical benefits for civil service eligible persons CSEPs by mode other than the public healthcare service. We have been exploring the provision of medical and dental benefits other than the public healthcare service. We have made use of the PPP, public-private partnership model, to provide medical and dental benefits. We have the pilot scheme on dental services, dental scaling for CSEPs. We have invited dental clinics to provide dental scaling services to civil service eligible persons, CSEPs. Regarding Chinese medicine services, we are operating relevant clinics under a tripartite collaboration model. We have also encouraged and facilitated civil servants to take out medical insurance plans. In 1996, the government introduced a voluntary medical insurance scheme for civil servants so that CSEPs will have more options based on their own circumstances and needs. They can seek insurance plans that are suitable for them. Regarding whether we should provide subsidies to CSEPs to purchase private medical insurance or provide group medical insurance plans, we actually talked about this last year. There are certain statutory organizations that will provide such group medical insurance plans or provide subsidies. However, often they would require co-payment by staff members, and we cannot exclude the possibility of CSEPs going back to the public healthcare service system. In fact, if we are to provide group medical insurance for 570,000 CSEPs, taking into account the annual premium of the insurance plan providing mid-range medical benefits is about $8,000 per person. It can be as high as $4.56 billion. And in fact, the actual amount will be higher because statutory organizations only insure serving employees and their families. That is, the insured are generally under the age of 65. If we are to provide healthcare vouchers, it will still be a significant amount, because if we take the cash voucher amount of $2,000 at the moment and we are to provide such service for 570,000 CSEPs, the amount can be as high as $1.14 billion. Considering the financial viability and due to the restrictions in the scope of service, the government has no plan to purchase group medical insurance for CSEPs, provide subsidies to take out medical insurance, or give out healthcare vouchers. We will continue to explore various ways to enhance the provision of civil service medical services. As for whether we can provide other medical services by the private healthcare sector to CSEP, we have to carefully examine and review other factors. We also have to draw reference from the effectiveness of the pilot scheme. That's it for my report. Thank you, Chair. We welcome members' suggestions. Will those who wish to speak please press the request to speak button. We have much time to talk about this item today. I therefore will not set a time limit. First, Dr. An Wen-yu. Thank you, Chair. Even though you are not going to set a time limit, as we have talked about this topic before, I will be brief. I want to ask about what is the situation on the abuse of medical and dental benefits by CSEPs. We heard that a new mechanism has been introduced to prevent abuse. I want to ask if this is the case with dental benefits. Are there people who would take long sick leaves? Do we have any other new mechanisms that would prevent abuse? Regarding abuse, if they are seeking treatment at the hospital authority, based on their conditions, the authority will set the next treatment date. If they do not think their condition requires further treatment, they will not give them a date for the next appointment. And in fact, the Department of Health clinics would work this way as well. Only if the relevant colleagues have the medical needs will they receive such services. So I think abuse is not exactly a serious issue. But for the long sick leaves, it may not necessarily relate to this topic. We would require sick leave certificates to be issued if long sick leaves are issued by medical practitioners and if there is doubt about certain cases, the Civil Service Bureau may direct the colleague to seek medical treatment at a hospital, authority, hospital, or clinic, and a more or less neutral conclusion will be reached. As for whether the colleague can come back for work, we will convene a panel which consists of members of the hospital authority to make sure there is no abuse. Thank you. I want to know if there are any concrete figures in the past 5 years. How many colleagues are suspected of abusing the mechanism? I do not have such figures on hand. I will go back and review such figures. I think there is not necessarily abuse of the mechanism, but for how many are directed to seek treatment from the hospital authority, I can go back and review such figures and provide such figures if possible. Well, I want to ask more questions on behalf of Dr. An. Does the administration have any figures on civil servants providing sick leave certificates from the hospital authority clinics or the private clinics? Do you have a ratio? If you have such figures, it would be clearer how many civil servants are seeking treatment from the public health care service. Well, Chair, we do not compile such figures. When sick leave certificates are submitted, we will, in general, have trust in our colleagues. Unless this is in doubt, we will have follow-up actions taken. I would also like to raise another point, whether it's for me or for other colleagues. If we seek treatment from private healthcare system, it may not necessarily be the case that there is a shortage of public healthcare services or any inadequacies. It's just that some colleagues may have been going to the practitioners that they have always gone to even before they were civil service, or that they may have serious illnesses and they opt for private inpatient services, or they may have family members or relatives who have sought treatment from certain medical practitioners that they have heard good things about. So there are many different reasons. It may not indicate exactly that there are inadequacies in the public healthcare service that they would seek private healthcare service. I think you should compile such figures so that we will have concrete information on how many civil servants. It would be a rough percentage, I assume, who have sought help from private medical practitioners. I believe it would facilitate our discussions. Chair, as I said earlier, there are many different reasons why civil servants would seek private healthcare services. It may not be due to inadequacies in the public healthcare system. So I would say that compiling such figures may not necessarily be cost effective. If one is sick in the middle of the night. If it is not serious, some colleagues may just seek private clinical services instead of going to an A&E because they think it would be less of a burden because their condition is not so serious. I think there is a problem. Should we compile such figures? We can't really interpret such figures rightly. Well, I think the government can think about whether to do that. Thank you.
Next, Mr. Kingsley Wong. I have 3 questions. Thank you, Chair. Retirement benefits are close to our heart, especially when it comes to civil servants on new terms of employment. After 3 years of employment, MPF contribution on the part of the government can reach 15%. Some ask whether they can take out additional medical insurance with the contributions. For a year of mid-range, 8,000 medical insurance. So for civil servants in the middle band, they only need to take 1% to 2% in order to take out medical insurance policies. So can the administration allow new civil servants to take out medical insurance? This will solve the problem of no support for medical insurance among civil servants upon retirement. Some civil servants reflected the provident fund does not come with any guarantee, and they do want to flexibly make use of their pensions. On healthcare vouchers, this is common. The government has been rolling out different healthcare vouchers. Can each civil servant be disbursed with $2,000 of healthcare vouchers for them to use in the private sector? It takes around $8 billion to purchase medical services from the hospital authority. So, $1.1 billion each year. Is it possible to allow CSEPs to use medical healthcare vouchers? They can use these vouchers in the GBA or in the private sector. We can give it some thought. Medical resources in Hong Kong, whether in the private sector or in the HA, are limited. Can we leverage the support of the GBA to solve the inadequacy of medical services in Hong Kong? The Health Bureau and the administration are considering using healthcare vouchers in the Grade 3A hospitals in the GBA. So we can consider buying properties for some disciplined services staff members in the GBA for retirement. So we can purchase medical services from the top hospitals in the GBA. This way, we can allow Hong Kong people to enjoy medical services in the GBA. We can provide subsidies to these CSEPs. In fact, many civil servants retire in the mainland. Hundreds of thousands of dollars are sufficient for CSEPs to purchase a large flat. 3 questions. Thank you, Chairman. First of all, whether CSEPs civil servants can use the provident fund, the employer contribution to take a medical insurance. Well, definitely, the contribution on the part of the employee cannot be used. That is according to law. can we allow civil servants to buy properties using this part of the money? We understand there are different demands among CS. Different CS may accord priority to different items. But it is important to provide retirement guarantee to civil servants with the provision of provident fund. Some may think one thing is more important than the other. The scheme may be rendered very complicated. Does the administration decide which is important upon retirement of civil servants? This will also undermine the benefits of civil servants upon retirement. If civil servants need to use medical healthcare services upon retirement, this will cause extra strain on the public coffers. So at this stage, we can consider this possibility. Next, on the cost, as Mr. Kingsley Wong mentioned, last August we submitted a paper to the panel, or to the subcommittee, for mid-range medical benefits. They are about 8,000 per person each year. We use the example of some statutory organizations as examples. That was based on the number of employees in the statutory organizations as well as their health conditions and age brackets. That was how we derived the results. In my introduction just now, these services have been expanded to not only CSEPs but also non-civil service contract workers. The insurance premiums are actually lower compared with the insurance premiums in the statutory organization surveyed in the last study. So, well, that is, it is viable with existing resources. So using the government contribution of the Provident Fund to allow civil servants to take out medical insurance, at this stage we consider not that appropriate. Next, on healthcare vouchers, we not only should give CS but also CSEPs healthcare vouchers of $2,000. This is an amount of expenditure. Some may not go to healthcare services in the public sector. In my introduction, I mentioned despite the private sector medical service provision, some civil servants may still turn to the public sector. They have their medical history within the public healthcare system. They may still want to return to the family's clinics. I won't go so far as to say that this phenomenon will become more common in the future. But some civil servants do consult both public doctors and private doctors. So will this phenomenon continue after the disbursement of healthcare vouchers? With our expenditure, it is not necessary to ease the burden on the public healthcare system, but the net expenditure should be taken seriously. We should really consider whether it is necessary to do so in light of the tight financial position of the government. The amount is not small either. It amounts to 200 million or so. regarding whether we'll use PPP leveraging on the support of the GBA, we need to consider the cost effectiveness, sustainability, as well as supervision. That is to say, whether we can ensure quality of services provided to civil servants. GBA is rather near. It is not a decisive factor. It is not the only factor with which we will reject this idea. There are different factors at play. Some medical records are also involved. That is how to facilitate the interchange of medical records. These are difficulties that we need to look into. As members have noticed, public-private partnership PPP should be for simpler medical issues. Instead, for rather complicated illnesses, they may take longer time to follow up on. I'm not rejecting this proposal outright. Well, Secretary, just now while you were answering Mr. Kingsley Wong's question, whether civil servants employed on new terms can be allowed to use their own contribution of the Provident Fund to take out medical insurance. You said that different civil servants have different demands. Well, this is understandable. But after devising a scheme or a system, you can allow civil servants to make their own choice. This way, you are not making a decision for civil servants either. You are simply providing a network. It is still the civil servants' calls. Under this scheme, they will receive less upon retirement, and then they will have to receive different resources from the government. And this is a circular argument, in my opinion. After a civil servant receives the Provident Fund upon retirement, if he or she loses all the money in the stock market, well, that is not controllable by the administration. So we should look at the issue from the other side. I don't think the current practice can help civil servants. I've heard from many civil servant groups. They do think this issue is worthy of consideration. Mr. Kingsley Wong mentioned this point because he wanted the administration to give it some serious thought. Indeed, it concerns the retirement benefits of civil servants employed on new terms. Pensionable officers are on the decrease. There will be fewer pensionable officers. How can we give civil servants peace of mind so that they will also enjoy medical benefits upon retirement? Well, I do think the administration should think about this. Probably those higher paid civil servants may only need to take a small portion of their pension. This is their own choice. At the end of the day, when civil servants grow older, they do need medical benefits. They do need to consult doctors. The question is whom they will turn to the public hospitals, to the public sector. Well, I don't think we should reject this proposal outright. Instead, we do need to take a look at the situation, conduct studies, outweigh the pros and cons. Well, I mean, we need to weigh up the pros and cons in order to decide the way forward. The Secretary just now mentioned the Greater Bay Area, GBA. That is indeed very good. I can see the Secretary is moving forward in this direction. I hope the Secretary will continue to adopt the same approach while considering the other 2 points referred to by Mr. Kingsley Wong. Any more follow-up, Mr. Wong?
Next, Dennis Leung. Mr. Dennis Leung. Chair, I would like to follow up on some figures. It is said that there are 570,000 CSEPs. But I want to have a breakdown, for example, how many existing civil servants there are, how many retired civil servants there are. I believe it would facilitate our discussions with such data so that we can consider whether there are indeed adequate medical and dental benefits for civil servants while ensuring that the government's budget is financially viable. We have every year civil servants retiring, so if we can have the trends, for example, whether the number is increasing or decreasing, that would be helpful. According to the Secretary, there is no information on how much is paid for the relevant services and whether civil servants are seeking medical services from the public or private sector. Some civil servants may indeed seek services from both public and the private healthcare system, but we need at least information on how much is provided by the government to the hospital authority to operate medical or healthcare services for CSEPs. Without such information, we don't know what the actual situation is. We also want to know if the hospital authority is operating services specifically for CSEPs or whether they are providing services that are tailored for general citizens. It's just that there may be charge concessions or total exemption of fees. For private companies, they would purchase medical insurance for employees. So as employees of private companies, they are entitled to additional benefits. So they may be seeking services from private medical practitioners. They may also go to the public healthcare system. Yet for civil servants, they do not necessarily have additional benefits. It's just that they may be able to get some concessionary charges or exemptions in fees and perhaps priority in the form of priority discs. It is said in the paper that the government considers the purchasing of group medical insurance or the subsidies to take out medical insurance to be impractical, but then for many people who are retired, this is a great burden. Will you consider or explore the possibility of people going back to the public healthcare system or making use of their own money after retirement, but providing them with such subsidies while they are in service? Thank you. Thank you, Chair. Right now, there are 175,000 in-service civil servants and 135,000 retired civil servants. There are 27,000 odd who are family members of civil servants. But these are not all of them. Some colleagues may have given birth to children. They are supposed to report this to us, but then they may just seek assistance or treatment from the public healthcare system, so these will not be accounted for. The retirement peak will soon be over. In fact, I said on multiple occasions before, in 2030, there will be several years where there won't be that many people retiring. But of course, we have multiple factors at play here. We have to consider the lifespan of the people of Hong Kong. It is getting longer, as you may know. So how many years will they be entitled for medical and dental benefits post-retirement? It is hard to predict now. With a longer lifespan, of course, they will need more in terms of healthcare services. We have a low fertility rate at the moment, so we have less children who are entitled to civil service, medical, and dental benefits. For the number of children, that would be a factor as well. As I said before, the people of Hong Kong have a relatively long lifespan. It demonstrates that we have a pretty good healthcare system. The number of retired civil servants is expected to increase even further. As for figures, it's not that we do not wish to compile such figures, it's that we can't compile such figures. Of course, the hospital authority would have a unit cost, but it is just a division of the total figure by the number of patients. But with different services, the actual unit cost would definitely be different, but this is not reflected in the figures. For certain support services or equipment, they will still need such even without services offered to civil servants. They will still need computers, they will need to maintain the relevant equipment. So these are lump sum costs that cannot necessarily be broken down. it's meaningless if we break it down. Some civil servants have such experience where they are going to A&E departments. They did not mention in advance that they were civil servants, so they ended up paying the full fee. So these will not be reflected in the figures. So I think the figures wouldn't be meaningful even if we were to compile them. Mr. Leung asked about whether civil service eligible persons get any form of additional benefits. Well, the major part of it would be concessionary fees offered to them for inpatient and outpatient services. Some employees who are entitled to company medical benefits will have concessionary fees when they seek treatment from private medical practitioners. It is a benefit provided to them by private companies. So with us providing concessionary fees for the public healthcare services, it would be a form of additional benefit. As for services specifically offered to CSEPs, in the hospital authority, we have 3 specialist outpatient clinics for CSEPs in Queen Mary Hospital, Queen Elizabeth Hospital, and Prince of Wales Hospital. We also have a diagnostic center for CSEPs specifically. We also have Chinese medicine services. We provide every year 100,000 places for CSEPs. We also have dental clinics operating services specifically for CSEPs. Regarding the reimbursement of medical fees for medical expenses for drugs, equipment, and services prescribed by hospital authority or Department of Health doctors, but are not available in hospital authority or Department of Health, it is possible to obtain a reimbursement of such expenses. Regarding concessionary fees, again, I would like to emphasize that this is a form of additional benefit. Regarding the last question of Mr. Dennis Leung on whether we would provide different services for different categories of CSEPs, I think this option would not be accepted by most CSEPs, and we actually have the same terms for all CS or civil servants at the moment. If we are to change that, we will need to consult colleagues first of all. And again, I think this option will not be accepted by most civil servants. We are offering the same terms to all civil servants regardless of ranks. That is out of fairness. So whether it's workman 1 or a permanent secretary, if they have the same kind of illness, they would be entitled to the same kind of service from the hospital authority. And if they seek a reimbursement of expenses, they will be entitled to the same amount. I think this is a fair, good system. So I think your suggestion may not be accepted by most civil servants. Thank you.
Any follow-up? No follow-up. Secretary, you just now mentioned the figures of the hospital authority. We've heard from the Secretary that there are breakdowns of figures such as equipment and so on. You need to detail the breakdown, but this is difficult. But it does not mean that we can't find the amount of money of medical services provided by the HA to CS. We need to adopt a broad brush approach. We do need to know how much the government gives to the hospital authority, as we can satisfy the medical needs of civil servants. The hospital authority does have money or surplus every year. Out of different reasons, the HA cannot provide services, but you still have given the HA the money. They can make better use of the money. For example, for some specialist services, the queue is too long. The HA should consider whether some money should be spent on the PPP. Some cases can be outsourced. Just an example, for diabetes patients, when their conditions become stable, the cases are referred to the private doctors. That is because the public sector cannot satisfy all the demands. In fact, when the HA still has surplus, it can do so. It can make use of PPP. When civil servants can consult government doctors, they have no choice but to turn to the private sector. So, Secretary, you can break down the figures. You can give us a detailed breakdown. We also mentioned this point on the last occasion. Next, Mr. Chao Su-chung. Thank you, Chairman. I'd like to talk about the benefits upon retirement for civil servants. For civil servants employed on new terms, they have literally no medical benefits. Many serving civil servants think that they have no benefits at all. Many bodies such as DHA or some private organizations, they do provide medical services for employees upon retirement. In fact, this can enhance employees' sense of belonging. This can also make the positions more attractive. The appeal of civil service positions has been declining. The administration should work on enhancing the sense of belonging among civil servants. It should also consider how we can retain talents in the government. I don't quite understand. When some private organizations or public organizations can provide medical benefits for employees upon retirement, why can't the administration consider providing medical benefits for civil servants on new terms? You can take baby steps. You should take one step forward each time. And I do think the administration should think long and hard about this. Just now, member mentioned using the voluntary contribution of the Provident Fund of civil servants to take out medical insurance for civil servants employed in new terms. This gives them a new option. To me, I welcome this suggestion. At least this is one more choice for civil servants employed on new terms. But on the one hand, we need to make sure this is down to the personal choice of civil servants. If they are not willing, they can still keep the money in their MPF account. We can also, through the administration, discuss with insurance companies some insurance terms. Well, that is some insurance policies that can be taken out in the context of not civil servants. We need to provide terms that are better than the terms in the market. We do need to provide better terms to civil servants. This will be an incentive. When we take out private insurance, what we are concerned about is whether the insurance renewal terms will be changed. That is, will the insurance premium be substantially increased upon retirement, or when you claim the insurance policy, will the insurance premiums be increased substantially? Given the large pool of the insured, well, I think we can discuss with insurance companies. This will be welcomed by civil servants. Turning to the next point, let me get back to the papers. As the chairman was making some summaries in the last meeting, the government provides medical benefits to civil servants, and this is a contractual obligation of the administration to civil servants. The hospital authority is tasked with this contractual obligation of providing medical services. But then the HA actually provides services to not only civil servants, but also members of the public. This will give members of the public not a very good perception, as if civil servants were competing for medical resources with members of the public. This is not a good perception. I hope the administration can come up with some methods so that some options can be thought out in order to fulfill the contractual obligations in addition to public healthcare services. Well, I mean, in addition to mode other than the public healthcare services. Many are let down by the papers. I did read through this information paper as well. 10 paragraphs were devoted to existing schemes, such as 11 insurance policies, but they failed to ease the burden on the public healthcare system. Nor can the contractual obligation of civil servants be fulfilled. That is exactly why we need to explore different ways, whether group insurance or not. Can we outsource dental scaling services? This is something good too. On the one hand, we can ease the pressure on public healthcare system. On the other hand, the administration will also fulfill its obligation or responsibility. In the conclusion of the information papers, the administration voted down medical insurance or group insurance, but I don't think the government should jump to this conclusion. First of all, the $4.5 billion were calculated on a rough basis. If the administration wants to work out a plan, can we commission a professional body or consultants in order to work out a plan. We can even consult companies with actuaries. We need to commission a consultancy study so that members of the public will be convinced the administration has given it some thought. That is, whether the administration can fulfill the contractual obligation owed to the civil servants. I hope the administration will give it some thought. That's all I want to say. Thank you, Chairman. Secretary, on 3 fronts. I believe Mr. Chow is particularly concerned about the conclusion drawn in the information papers. In other words, are there any concrete suggestions, that is, commissioning a consultant to work on a consultancy study to identify the issues, what problems we need to address, so that there will be a solid basis on which we can solve the problems or address the problems? Thank you, Chair. Regarding the first point mentioned by Mr. Chow, that is the employer in the private sector. Based on what we understand, I dare not say all, but the majority of these employers in the private sector do not provide medical benefits upon the retirement of their employees. In Hong Kong, when employees retire, apart from the government, only the hospital authority provides these medical benefits. Even the statutory organizations do not provide medical benefits for employees upon retirement. So the government does not lose out to any statutory organization or private sector. You can at most say that we provide the same level of benefits. Next, using employees' contribution of the Provident Fund to take out medical insurance, as I introduced. There is currently a system, that is the voluntary medical insurance scheme for civil servants. It's a little bit akin to what Mr. Chow said. What medical insurance policies are included, it is not down to the government to make a decision. Actually, different committees put their heads together to decide what is the most popular among civil servants. As I mentioned, there are over 10 schemes under the voluntary medical insurance scheme. Let me cite one example that is quite well received or quite popular. I'm not going to say private wards, as some prefer private wards, some prefer suites. Let's just talk about ordinary private wards. For civil servants aged between 50 and 59, for 100% of reimbursement of medical insurance fees, that is, civil servants do not have to pay anything at all. The insurance premium is only $5,061 per year. That is the annual insurance premium. From the reference information about the 3 statutory organizations provided last year, the base figures contained different age brackets. So, I mean, this is affordable. For civil servants between the age of 40 and 44, the insurance premium is $2,973. it is also popular among civil servants. So, do we really need to use the employees' contribution of the Provident Fund? This is worthy of consideration or discussion. Mr. Chow also mentioned another point. What about after retirement? Well, of course, these schemes will not stay the same after the retirement of employees. Among these 11 schemes, some schemes are actually promoted by the Health Bureau. They are under the Voluntary Health Insurance Schemes, VHS. So insurance premiums will be increased across the board, not targeting a particular category of people. For voluntary medical insurance scheme, some civil servants can choose some schemes under Voluntary Health Insurance Scheme VHIS. This is the current situation. Mr. Chow also mentioned whether we can engage actuaries to look at the situation. Well, we are actually well up in the situation. As long as the insurance pool is large enough, the insurance premium, as I explained, will also be lower. It depends on the risk levels of people in the pool. So, for the voluntary medical insurance scheme for civil servants, or making reference to the products and market, we can already make comparisons. We do not need to spend another money on the consultancy study. Just now, we used the mid-range medical benefits for insurance plans in the statutory organizations. Some may ask whether the insurance premiums will be lower given the larger pool of civil servants. There are other factors at play. Mr. Dennis Leung also asked about this. With the increasing or longer lifespan, the risk level will be higher, hence the higher insurance premiums. We need to bear in mind we do have 570,000 CSEPs with us. Thank you.
Secretary, if you refer to paragraph 9 of the paper, it says that several representatives of staff councils will be involved. We do not know about the details. You said that there are a cumulative total of approximately 38,000 policies. But what is the distribution? Who are the policy holders of these policies? What are their ranks? If you can provide more details, it will facilitate our discussions. You said earlier the figure is quite low. It would only take 5,000 odd in premium per year, so that would make for $400 odd per month. And for those appointed on the new terms, they only have to spend $400 odd per month to purchase voluntary medical insurance. That is very attractive. And if this can continue upon retirement, that is very ideal. So my impression is that we really should look into this. Overall speaking, for those appointed on the new terms, it is said that no medical benefits will be provided to them. They will end up in the public healthcare system. So it's just the difference of whether they have to pay the fees charged by the public healthcare system. There are more and more civil servants appointed on new terms, and there will be less on pensionable terms. In order to retain those appointed on the new terms, we should really look into this. Of course, many private companies do not offer post-retirement medical benefits, but then private companies offer other competitive benefits. The administration's existing arrangements only allow for civil servants to pay concessionary fees for public healthcare services while they're in service. Why can't you offer such upon retirement in order to enhance competitiveness? It actually doesn't cost that much. It is just providing concessions to civil servants post-retirement. It doesn't necessarily make much of a difference. So we should really look into whether we should offer medical protection to retired civil servants. I think that would help retain civil servants and facilitate or encourage them to be more dedicated. If the government can offer comprehensive medical protection to them, they will be more dedicated to their work. We have the next member who is going to speak, who is Mr. Kwok Wai Kung. Thank you, Chair. We have a manpower shortage for many sectors, so we really have to do more to retain civil servants. We should take a preemptive approach. We shouldn't wait until the civil servants have left to do something. We should offer competitive packages to minimize the chances of civil servants leaving for other sectors. We should also offer some sort of flexibility to provide civil servants with more options. There is a stereotype. Many people would think that civil servants are entitled to very attractive benefits, but that is no longer the case for those appointed on the new terms. They would have various concerns, and they feel that the terms that they are entitled to compared to those on pensionable terms are unfair. In order to retain talents, we have to consider first the manpower demand. For those who are sick, they will be absent from work, and that will definitely affect the work of the government as well as quality of services provided to the public. That's why we should improve the benefits, medical and dental benefits provided to civil servants. I believe most people would think that the pilot scheme on dental scaling services is a beneficial scheme, and it was asked before, from what I remember, whether any additional expenditure would be incurred. It is said that there won't be any such, but is it due to the fact that we cannot hire additional dentists, that we do not incur additional expenditure. I can see those from the Bureau nodding. Since we do not have adequate government dentists, why don't you allow for civil servants to obtain services outside of the public healthcare system, just like what we are doing with dental scaling services? I understand that in recent discussions of MSW charging, people would often say that if one is unclear about something, is it due to one not wanting to be clear about something? If we do not resolve the problem, I think things would just remain unclear. I asked a question of the hospital authority before, and the answer I got, it was last year or the year before, it was said that $5 billion were earmarked to provide services to CSEPs. Is this figure calculated on a cost basis? So CSEPs, I would assume they are all locals. They are civil servants, thus they are entitled to such services, and the hospital authority should provide a specific figure so that we'll have a better understanding of the situation. They have a shortage of doctors and dentists, and civil servants cannot obtain the services that they are entitled to, and that's why the hospital authority would have provisions left over, which is why they should return the provisions to the government so that the government can make use of such funds to provide private healthcare services to civil servants and their civil service eligible persons. Well, I think the administration can offer flexibility in providing an option to civil servants to make use of voluntary contributions to purchase voluntary medical insurance. Right now, we have 38,000 policies and 55,000 policy holders under the voluntary medical insurance scheme for civil servants. I assume many of those cannot wait for public healthcare services. That's why they have decided to take out private medical insurance. If you can offer flexibility in this regard so that civil servants can purchase voluntary medical insurance, that would make for a larger pool, as the secretary said, and the insurance premiums can lower even further. With tight finances, we should come up with ways to make better use of our funds. You are saying that because it would cost $8,000 per person, and the annual expenditure on procuring group medical insurance could be as high as $4.56 billion, and you're closing the door on this. I think you can think about the relevant options, weigh up the pros and cons. If you just close the door on this option, civil servants may not be convinced. We want to find out about the truth. We want to see what we can do better. So I think there should be a comprehensive consultancy study to look into these. in the end, is it the case that if you offer another option that people will necessarily take this option? It indeed may not be the case, but for those of higher ranks, they may opt for that. Of course, this should remain voluntary, but I hope the administration can do more for those appointed on the new terms.
Thank you, Chairman. Before the Secretary answers the question, I'd like to say something. If civil servants employed in new terms take out medical insurance, if there are more civil servants like this, it's not only a personal choice for these civil servants. Well, we should bear in mind when a person is sick, he or she turns to a private doctor, then he or she does not have to go to a public doctor. The supply is fixed. When the demand is fewer, then the waiting line becomes shorter. There are actually benefits, just like the situation of dental scaling. The waiting line is shorter. The response was not that ideal because civil servants did not quite understand the details. When there are more supply options, naturally enough, there will be less demand. Well, civil servants asked about better working hours, 5-day work week. The head of grade should think about all these. When you apply these principles to the current situation, it is actually the same. We are not asking the administration to take money out of their own pocket to work on this. Instead, this amount of money has already been used in some areas, and we need to think whether we can improve the use of money so that civil servants will think that they are actually enjoying better medical benefits. Well, excuse me, I'd like to chip in, Chairman. The administration should help ask the colleagues. If civil servants are ill, but then they recover the same day, are they willing to use the employee contribution of the Provident Fund? Secretary, as I mentioned, the historical background is like that. Before 1990, there was a department about healthcare within the government. Back then, government provided medical services to civil servants. There wasn't a separate budget. Afterwards, after years of changes from one bureau to another, the practice is actually the same. The HA does have its own personnel section. When there are fewer civil servants going to the HA for medical consultation, it does not mean that there can be fewer staffers in the personnel section. Just like hospitals need to purchase a piece of equipment. Whether there are 3 civil servants or no civil servants at all, it does not affect the decision that the hospital needs to purchase a piece of equipment. So it is almost impossible to have a breakdown of the figures. Just now, Mr. Kwok mentioned the figure. Well, it should be $6.5 billion if I remember correctly. The HA does have a simple unit cost for different specialist medical services or different diseases. this is a greatly simplified figure. It is not accurate either. So, I'm still willing to explain to members that it's quite impossible to have a detailed breakdown of figures. Even if we were able to do so, could we take away this amount of money and give it to civil servants? As civil servants could still go to the HA as an ordinary member of the public. We just can't forbid civil servants from visiting the HA. If they are seeking medical services as members of the public, how should we calculate the figures? I want members to understand. On a different note, regarding insurance plans, there are different force councils scrutinizing the insurance premiums of insurance products. Just now, Chairman calculated the monthly fee is some $400. And civil servants do not have to use the employees' contribution of the Provident Fund for civil servants. They can still afford it. Let's not forget the design of Provident Fund for civil servants. The contribution is actually based on the income of civil servants. For lower band civil servants, the contributions will also be lower. So they can do the math and they can see whether they can afford the medical insurance. If they take out a portion of money from the employee's contribution, they need to think whether they can do so. That is because their income is lower, hence a smaller amount of contribution. When they take out that amount of money, they will enjoy actually less guarantee or safeguard upon retirement. When civil servants take out insurance, as I mentioned, the voluntary medical insurance scheme for civil servants, it is providing services to 170,000 civil servants as well as their family members. The pool is actually large enough right now. If civil servants take out a portion of money from their employees' contribution of the Provident Fund for civil servants, it does not help the situation. The reason why the contribution is actually cheaper is that the number of people in the pool has been factored in. So when civil servants take out other medical insurance plans, there will be a significant impact on insurance premiums. Well, I'm afraid I don't quite agree with the Secretary. The more people you have, the better terms you will be able to bargain. Businesses actually focus on how many businesses they can get. When businesses can secure more businesses, well, of course, they will then have to provide better terms. If civil servants cannot take money out of their own pocket and they do not want to take money from their employees' contribution of the Provident Fund scheme, it's their own personal choice. We don't have a crystal ball. We don't know how the future will pan out. When some people turn to the private sector, there will be less pressure on the public sector. And the scheme is about a voluntary basis. It is not a mandatory basis. So the government does not have to make a decision for civil servants. Instead, you are providing a very good platform to attract civil servants to do so. It's all down to the civil servants whether they will take part in it or not. Probably they will say, I'm not going to take the money out from the employee's contribution. I can pay out of my own pocket. That works as well. There are many possible ways to deal with this situation. Second round, Mr. Chao Siu-chung. Thank you, Chairman. I'd like to talk to the Secretary about the pilot scheme on dental services dental scaling for civil service eligible persons. I'm glad to share with the Secretary that over the past 2 months, some civil service reflected to me that the dental scaling services are actually quite good. They had never enjoyed better dental scaling services. They've had the brightest teeth ever, the whitest ever. The participation rate is 31%. It is not quite ideal. When we roll out the scheme, we do want to have a higher participation rate. In the last meeting, the chairperson also made a summary, including sending email messages to CS or even sending physical letters to civil servants or arranging for phone calls to be made to civil servants in order to directly invite them to join these services. After these 2 months, has the administration worked on this area, or has the administration taken on board our recommendations? Next, a number of civil servants told me that when they identified any dental issue during the dental scaling consultation, according to the scheme, their cases will be referred to the public sector. And the dental clinics of the Department of Health will follow up on the cases as soon as possible. But some civil servants still have this worry. That is whether they'll still have to wait for a long time for a dental checkup. The administration can provide me with figures right now, but if you do have examples or a pledge right now, what is your pledge? That is, how long will the civil servants have to wait? If you can give us a pledge, you'll give civil servants peace of mind. You can also ease the pressure on the public healthcare system. After 12 months, the administration said that they would initiate a review about the system. On top of the participation rate, we also need to see how many slots can be freed up. That is for the use of the civil servants still within the system or for general members of the public. After half a year, have we looked at the figures? 20,000 or so have participated in the scheme. So how many consultation slots have been freed up? Will we set any KPI regarding this? How many consultation slots can be freed up with the scheme? What is the expectation of the government so that we'll increase the number of participants or even regularize the scheme after the 18th month implementation period? Secretary. Thank you, Chairman. Just now, Mr. Chao has summarized what we have done in order to boost the participation rate. It was rolled out last July. We arrange for civil servants with a booking time in early 2024 to enjoy the services. The original target was the first few months in 2024. Some civil servants may prefer staying in their own queue. when the consultation slots are postponed, the dental scaling services will be even more attractive, as they have to wait for probably 8 months, 10 months, or even a year before they can enjoy the dental scaling services. If they can enjoy these services earlier, this will be more attractive. The participation rate is 31% while we were preparing the documents. Right now, the figure stands at 35%. We will not be content with it. We will continue to make enhancements. We won't let any consultation time slot go to waste. If other dental issues are identified, what is the time frame civil servants need to wait? Well, I can't give you a detailed or accurate figure right now. It depends on the complexity of the situation. How serious is the situation? Is a dental issue of the civil servant? Are the teeth fractured? Is the root canal affected? It also depends on the location of the clinics. If the clinic is more popular with a longer queue, the wait will be longer. So I can give civil servants peace of mind. If other dental issues are identified during the dental scaling services, these issues will be followed up on by the DOH. Well, and they can even return to the DOH for the second dental scaling services appointment. Regarding the next question, how many consultation time slots can be freed up? The purpose of the pilot scheme the pilot scheme is actually a simple one. So, with the introduction of the pilot scheme, civil servants can enjoy a shorter time before they can use the services. We can already see the results. The dental clinics of DOH have their consultation time slots used up. So the time slots further down in the future will be advanced. More civil servants will be able to enjoy the services earlier. Some time slots may be as long as half an hour, whereas some services may take longer time, probably 2 hours or even 3 hours. That is for more complicated dental procedures or checkups. So it's kind of difficult for me to pinpoint the number of people that can benefit from it. These consultation time slots will be used in the future, and it depends on the individual circumstances of different civil servants. So I can't provide you with a concrete figure right now.
All right, members do not have any other questions. Well, before I give a conclusion, Mr. Kwok Wai Keung, please. Excuse me, Chairman. The Secretary did give me an answer before. I understand where the Secretary was coming from. It would be hard to earmark a provision specifically for services offered by the hospital authority to CSEPs, but we can see that with the pilot scheme on dental scaling services, it was introduced due to the shortage of dentists. We can see that the hospital authority has such a surplus, has such a huge surplus, and how much of that surplus is derived from the shortage of medical practitioners or dentists, and how much of that is due to the shortage of services provided to CSEPs. I really want to know that. I want to know what difficulties the administration faces in relation to retirement protection. If you can offer more options to civil servants, that would obviously be ideal. So are such difficulties technical, or are there any other form of difficulties? We have sought advice from the staff side councils, and they definitely think such option is agreeable. Can the administration explain why it is the case that a consultancy study cannot be completed? Why can't you look into this option? Can you elaborate? Thank you. Regarding the first question of Mr. Kwok Wai Kung, I would like to supplement some information for the shortage of medical practitioners. Can we use such leftover provisions for services? I think we have to think about this. It would depend on the seriousness of the condition of patients. If it is more serious, obviously their wait will be shorter. I myself do not know about the specific details, but I would think there are different factors at play here. It is a very complex issue. You have to think about, for example, the seriousness of condition. Dental scaling is a relatively simple dental service, and this is a service that can be specifically offered to CSEPs. It is easy to carve this out from other forms of expenditure. It's not so much so with other services. Regarding retirement protection, the Civil Service Pension Fund Scheme's intention is to provide adequate retirement protection to civil servants. It's the same for those on pensionable terms. We just want to provide adequate protection to civil servants, whether they're appointed on pensionable or new terms. If they withdraw the funds before retirement, it will be a conflict with the policy intent. So for those after purchasing insurance after retirement, they would have higher premiums. So why aren't we providing retirement protection? As we said earlier, we have still the voluntary medical insurance scheme for civil servants. That's why, in principle, I won't agree with what you said. Well, I think, in principle, the administration is making a huge mistake. We have 3 pillars. One is the MPF. In order to provide better retirement protection, the government has made a greater or a larger amount of voluntary contribution for civil servants appointed on the new terms. So you won't allow for voluntary contributions to be withdrawn freely by civil servants. If you allow for a small percentage to be taken out, I don't think it is against your principles. You have to understand this. You have to come up with schemes that have been consulted fully. And after all, this is an option that one can participate in voluntarily. So I think that in principle the administration shouldn't have any problem with this. For the details, we can always talk about them to flesh them out. I hope that the administration can provide a paper that is on the voluntary medical insurance scheme for civil servants, specifically how many of those on pensionable terms have participated in the scheme, how many on the new terms are participating in the scheme, and how much in contribution have they made. Now, I'll give a short summary of what I heard during this meeting. I think that members generally were dissatisfied with the conclusion that the administration gave in the paper. It is believed that the administration should fulfill the relevant contractual obligations to provide timely and appropriate medical services to civil servants, and the existing arrangements of the administration do not meet the needs of civil servants. That's why, in general, members believe that the administration should look into the issue to see if a consultancy study can be conducted to support its stance. It would be best if a consultant can be engaged to study whether it is indeed not feasible. We will need solid data justifications. So members requested that the administration consider allowing civil servants appointed on the new terms to take out a small percentage of the Provident Fund contributions to purchase medical insurance. Regarding the services provided by the hospital authority to civil servants, what would happen to the remaining provisions for those on stable condition? Will the administration consider adopting the PPP model, allowing private operators to follow up on such cases to reduce the demand for public health care services? It would depend on how much the administration has provided in funding to the hospital authority. It may not be an exact figure, but if we have at least a rough figure, it will facilitate our discussions on the allocation of resources. Also, regarding the medical expenditure or provisions provided to civil servants, we should consider whether it can be cashed out in the form of healthcare vouchers so that members or civil servants can make use of that for services in the Greater Bay Area. Do members have anything to add? If not, this is the end of the discussion of this item. The last agenda item is any other business. If there is no other business, meeting adjourned. Thank you.